this module of genetic disorders, I'll be discussing aneuploidies, microdeletion syndrome, genomic imprinting disorders, and other group of genetic syndromes which are commonly asked in the exams. We will start with the discussion of aneuploidies. What is the meaning of this? It is a difference in the number of chromosome. We all know that there are 46 chromosomes in every cell. If there is a difference in that number, we call it as an aneuploidy. The common aneuploidies are trisomies, which includes an extra chromosome. For example, trisomy 21 refers to an extra chromosome 21. Instead of normal 2 chromosomes, that person will have 3 chromosome 21. That is called trisomy 21. The other group is called as a monosomy, wherein instead of a pair or 2 chromosomes, there is only 1 chromosome in that pair. We call it as a monosomy. For example, monosomy X in a female refers to only 1 X chromosome. Normally, there are 2 X chromosomes in a female, so only 1 X chromosome is called as monosomy X. Okay, let us start discussing the individual disorders in this category of trisomies and monosomies. We will start with the most common trisomy, and that is Down syndrome. So, Down syndrome, which is trisomy 21, is the most common trisomy. It is also the most common trisomy noted in live-born babies. Okay. Second important point about Down syndrome is it is the most common genetic cause of low IQ. We know that most of the genetic syndromes will have a low IQ, and among them, the most common genetic cause is always Down syndrome. Low IQ is also called as intellectual disability. Now let us see what is the genetic mechanism behind the occurrence of Down syndrome or genetic basis of Down syndrome. The most common reason is maternal meiotic non-disjunction. So what happens in the mother during the meiosis time? There is non-separation or non-disjunction of chromosome 21 during meiosis. That is the most common cause for Down syndrome, and this accounts for 95% cases of Down syndrome. The second common reason is something which is associated with Robertsonian translocation. What is Robertsonian translocation? It refers to a translocation between 2 acrocentric chromosomes. The commonly encountered Robertsonian translocation varieties in Down syndrome include translocation 14-21 and translocation 21-21. This accounts for 4% of cases. And the last category, which is just 1% of case, is something called as mosaicism. Mosaicism is a condition where you will have mixture of both trisomy 21 cells as well as normal cells in that particular child. This accounts for 1% of cases. So overall, most common genetic mechanism is maternal meiotic non-disjunction. The external appearance of a child with Down syndrome is so characteristic that you can make the diagnosis just by looking at the child itself. So that is why in your exams, when they ask you about Down syndrome, they can even put up the pictures of Down syndrome and can ask you about the diagnosis or to tell about the investigation required to make the diagnosis. So let us look at it in detail. The first thing which will be striking is the appearance of the child's face. This is a dysmorphic or an abnormally looking face in Down syndrome. What are the findings you note? Number one finding is look at the eyes. The eyes are not oriented normally. You can see that the eyes are oriented upwards like this. Okay, this is what we call it as the mongoloid slant of the eyes. Mongoloid slant of the eyes. Mongoloid slant is nothing but upslanting of the palpebral fissures. Okay. That is a number one striking feature when you look at the eye of the child. Second thing, if you look closely in the iris, you will have some white spots called as the brush-field spots. This has been asked as an exam question. What are the white spots in the iris of a child with Down syndrome? It's called as a brush-field spots. Third important is there is an increased space between the nose and the eyes, as you can note. This is because of an extra fold of skin in that region called as the epicanthal folds. Then when you look at the nose of this child, okay, especially from the lateral view, that is the second picture in this slide, you can see that this is a flat nose. You can also notice in the same picture that the back of the head, that is the occipital region, also appears to be flat. So they have flat occiput. In general, the face also appears to be flat. We call it as a flat face. And the typical description of the appearance of the skull in a child with Down syndrome is called as brachycephaly. Next, we come to the ear. Now, how do you assess this particular child ears? You drop an imaginary line from the back of the outer canthus. Okay. Now, in all of us, a part of the ear should be above this imaginary line. But you can very clearly notice in this particular child, the entire ear is below that imaginary line. This is what we call it as low set ears. Okay, right. Then we come to the mouth region. You can see that in the mouth region, it is a protruding tongue which is present. Can you notice here? There is a protruding tongue from the mouth region. Okay. The reason for this protruding tongue is because of the underdeveloped or hypoplastic mandible. So hypoplastic mandible is another important feature noted in these children. Okay. These are the main points to be noted in the facial appearance of a child with Down syndrome. Okay, right. Now coming to the other appearances, when you look at the hands and when you look at the transverse crease in the hands, I'm talking about the horizontal crease in the hand. Normally, all of us have two transverse or horizontal creases, but a child with the Down syndrome has a single transverse crease in the palm. Single transverse palmar crease, which is also called as the simian crease. Okay, and also the little finger, okay, is slightly curved. That is what we call it as clinodactyly. Clinodactyly. Clino refers to the curved and dactyly refers to the finger. So it is the curved finger, especially the little finger is usually curved in case of Down syndrome. Okay, and in the foot, you have a increased space or a wide gap between the first and the second toe. Okay, wide gap between the first and the second toe, and this is called as the sandal gap. Okay, these are the important external appearances in a child with Down syndrome, based on which we can make our diagnosis clinically that it's a case of Down syndrome. Please remember that Down syndrome is not only a problem of external appearances, there are so many internal problems or internal associations in a child with Down syndrome. We all know that these children have low IQ. They also have hypotonia. Okay. This condition is also associated with increased anomalies or defects in the internal organs as well. And if there is a question, what is the most commonly affected organ in a child with Down syndrome? Or they can also ask you the question like, which organ problem is the common cause of morbidity and mortality in a child with Down syndrome? Then your answer has to be cardiovascular defect. It is the cardiac defects which are a main problem in a child with Down syndrome. 50% of children with Down syndrome have a cardiac problem, and the most common cardiac problem is endocardial cushion defect. Endocardial cushion defect. It is also called as atrioventricular septal defect. That is the most common heart defect in a child with Down syndrome. The second common heart defect is VSD alone, and third common heart defect is ASD alone. Okay, this is the sequence of the most common cardiac defects encountered in Down syndrome. Other than cardiac defect, they can also have increased incidence of gastrointestinal defects. The most common gastrointestinal defect is atresia, and that too duodenal atresia. This is a commonly asked exam question. The most common cause of intestinal atresia in a child with Down syndrome, it is duodenal atresia. The other GI anomalies associated include Hirschsprung disease as well as annular pancreas. They also have an increased risk of hypothyroidism. So it's very, very essential that you keep monitoring these children thyroid function test, and whenever it is detected, prompt treatment has to be started. So in 1/3 of cases, or around 30% of cases, there is a risk of hypothyroidism which should be carefully monitored. Okay. These children also have an increased risk of cancers, and that too cancers of the blood. Okay, and the most common cancer encountered is the acute lymphoblastic leukemia. This is a commonly asked exam question. ALL is the most common type of leukemia encountered in Down syndrome. However, if the question is asking specifically in a child less than 3 years and Down syndrome, what is the overall most common leukemia? Then your answer has to be AML. What is that? Acute myeloid leukemia. And which variety? It is M7 variety, which is megakaryocytic leukemia. So please remember that only in children less than 3 years, AML M7 is very common. But across all age groups, remember the overall most common leukemia is ALL only. Okay, right. The next important point is these children have a risk of developing Alzheimer's disease. We all know Alzheimer's disease is a senile disease which is associated with old age. But these children, they have pre-senile Alzheimer's disease. Pre-senile Alzheimer's disease. What is the meaning of this? Say, generally Alzheimer's disease develops around 80 to 90 years. Imagine like that. These children will develop by around 40 years itself. Or in other words, by 4th decade itself, they develop Alzheimer's disease. That is why it's called pre-senile Alzheimer's disease. One of the reasons which is attributed is they have an extra chromosome 21. That is what is trisomy 21. This chromosome 21 has got a specific gene which codes for amyloid precursor protein, which I am abbreviating and writing as APP, amyloid precursor protein. So what happens, because of that extra copy of the chromosome 21, there is more production of this beta amyloid from this amyloid precursor protein, and that builds up in the brain, predisposing this child to develop Alzheimer's disease. This is the reason which is proposed as to why children with Down syndrome have a pre-senile Alzheimer's disease. When you look at the neck of these children with Down syndrome, it appears to be short, and when you investigate these children, some of them also have something called as an atlantoaxial subluxation. Atlantoaxial subluxation. This is a very important condition which should be diagnosed before these children start taking part in sports activities like contact sports, because this atlantoaxial subluxation, if identified, can result in significant problems later on. That is why these children are advised screening neck X-ray to identify this condition by the age of 3 to 5 years. So you take the X-ray, and if you identify atlantoaxial subluxation, you should advise these children to avoid taking part in contact sports activities. So these are the important associated problems in a child with Down syndrome. So you can understand very clearly that a child with Down syndrome after birth is going to face lot of difficulties in the real world. So it is always advisable to do the early diagnosis of Down syndrome starting from the antenatal period itself. So when we talk about antenatal diagnosis of Down syndrome, it can be based on screening test, and the second one is confirmatory test. Screening test could be done by radiological investigation or the blood investigations. The radiological investigation includes the antenatal ultrasound. In the antenatal ultrasound, the commonly used marker is increase in nuchal thickness or translucency. Nuchal thickness or translucency. Nuchal translucency is usually detected in the first trimester and thickness is detected in the second trimester, and when the value is more than or equal to 3 millimeter, it is suggestive of a pregnancy with Down syndrome. It is not a confirmatory test but just a screening test. And also in the ultrasound you can have other markers, or what we call it as clues to possibility of a Down syndrome or a trisomy. Again, these are not specific finding, only markers to suggest that there is a possibility of a Down syndrome. What are they? They include hypoplastic or absent nasal bone, short femur, and echogenic focus in the heart. These are some of the markers in the antenatal ultrasound which can point towards the possibility of a trisomy. Okay, so one is antenatal ultrasound. Second is based on the markers which we can obtain from the maternal blood. There are a different set of markers according to each trimester of pregnancy. Okay, in the first trimester, what we use is something called as a double test, which combines PAP-A and beta HCG. What is PAP-A? PAP-A is an expansion for pregnancy associated plasma protein A. Beta HCG, most of you must be knowing it. HCG is human chorionic gonadotropin. Combination of these two is what we call it as double test, usually done in the first trimester. Then in the second trimester, we can do something called as a triple test, which includes again beta HCG, alpha fetoprotein, and one more is unconjugated estriol. Combination of these three is what we call it as a triple test. In the second trimester again, if you combine these three markers along with inhibin A, you will get 4 markers, and that would be called as quadruple test. Okay, so these are the commonly employed maternal serum markers which can help in identifying a fetus with Down syndrome during pregnancy. What you should also know about is interpretation of these markers, or in other words, what happens to the level of the markers in a baby with Down syndrome during pregnancy. Please remember this, beta HCG and inhibin A will be elevated, whereas the other markers levels would be decreased. This is the general interpretation in a pregnancy with Down syndrome. Okay, HCG and inhibin will be elevated and other markers are decreased. What is generally used in pregnancy is a combination of this ultrasound as well as this marker testing. Okay, and we call them by different name. For example, combined test refers to the first trimester ultrasound with a double test. What do you do in the first trimester ultrasound? You look for increased nuchal translucency. This is called as a combined test. The next one is called as the integrated test, which includes the combined test plus the quadruple test, which is done in the second trimester. This is what we call it as integrated test. There is one more newly introduced screening test called as CFF DNA testing, which is cell-free fetal DNA testing. So what happens here, some of the fetal DNA comes out from the fetal cells and enters into the maternal circulation, and this can be detected by testing the blood sample from the mother. This is what is called as cell-free fetal DNA testing. It is also called as NIPT, which is non-invasive prenatal testing. These are all the important screening tests which are available for detecting Down syndrome in pregnancy. Next, going on to the confirmatory test or the diagnostic test. Please remember, the only way by which we can make a diagnosis 100% surely is by testing the karyotype. Okay, because karyotyping of the fetal material, if it reveals trisomy 21, then your diagnosis of Down syndrome is confirmed. How to obtain this fetal material during pregnancy? It can be done by invasive test only. Invasive testing. The different options include 1. CVS or chorionic villus sampling, which is usually done between 11 to 13 weeks of gestation. Second is amniocentesis, which is done around 15 weeks of gestation. These are the usual two ways by which we can obtain the fetal material for karyotyping. But please remember, these are invasive testing and there is a very slight possibility, like 0.5 to 1% possibility of inducing abortion or termination also. So that is why before we go for the confirmatory testing, we always do the screening test, and if the screening test shows high risk for a baby with Down syndrome, then only we go for the confirmatory testing. So please remember, initially screening test, if the screening test show a high risk of Down syndrome, then only we go for the confirmatory testing. So this is about the antenatal detection of Down syndrome in pregnancy. We should also know about the recurrent risk of Down syndrome in a pregnancy. This is very important in the antenatal counseling. The general risk of Down syndrome in any pregnancy, irrespective of the age of the mother, is 1%. Okay. Suppose the mother is having an advanced maternal age, which is defined by an age more than 35 years. The risk is slightly increased and the maximum risk is around 4%. Okay. However, if the parents are carrying a translocation, I am talking about Robertsonian translocation, then there is an increased risk of Down syndrome in the next pregnancy. Okay, and it depends on what type of translocation they are having. Okay, as I said before, there are two types of translocations which are possible, which is translocation 14-21 and the other one is translocation 21-21. If it is translocation 14-21 and if the father is carrying the translocation, then the risk of Down syndrome in the pregnancy is less than 5%. Books say around 3 to 5%. Whereas if the mother is carrying the translocation, then it is slightly increased risk around 10 to 15%. Okay. However, if it is translocation 21-21 in either the father or in the mother, you know how much is the risk of Down syndrome in pregnancy? It is 100%. Very, very important. So that means this couple in which either one of them have translocation 21-21, they cannot have a baby which is normal. Always they will have a baby which is Down syndrome 21. So that is why this type of question was asked once in the exam. You are evaluating a child with a Down syndrome. The karyotyping is trisomy 21 with translocation 21-21. Okay. And a parent is also having the same translocation 21-21. What is the future option for this couple who is having translocation 21-21? What should be the answer? They can never have a baby who is normal. So the only option for them to have a normal baby is to have adoption only. That was the answer which was expected for that particular question. Okay. So this completes our discussion of Down syndrome, which is the most common trisomy. Now let us look at the other common trisomies as well. Trisomy 16 has got no name, but the important point about trisomy 16, it is the one which is most commonly associated with spontaneous abortions during pregnancy. So the most common trisomy associated spontaneous abortion is trisomy 16. That is the only thing. There are no features to be remembered. There is no name for this condition also. This only one-liner is possible in your exam. Next is trisomy 18 and trisomy 13. Here I will be discussing elaborately about the features of these two trisomies. Just the names I am going to write here. Trisomy 18 is the second most common overall trisomy. The first most common overall is Down syndrome only. Second most common is trisomy 18, which is also called as the Edward syndrome. And the next trisomy is trisomy 13, which is also called as the Patau syndrome. Now let us see some of the important characteristic features of Edward syndrome and Patau syndrome. This picture depicts the characteristic findings in Edward syndrome. The first thing which will always strike is the appearance of the head in these children. Now in this particular child, you can see that the backside of the head is appearing to be prominent, and that is the number one characteristic feature, which is prominence of the occiput. The second important feature is in the eye region. Okay, remember these children have a small eye called as the microphthalmia, and they have short or what is called as tight palpebral fissures. Okay, next thing, it is not shown in this picture, but please remember they have an increased risk of cleft lip as well as cleft palate. Not shown in this picture, but many children have that particular problem. Okay, the next thing which is striking is in the hands of this child, which is shown in this particular area. Okay, you can see that it's a clenched hand. Okay, that is what is written as closed fist. Okay, and one more important finding which you can notice is the fingers are overlapping with each other. Can you notice here the fifth finger and the fourth finger are overlapping with each other, and here you can see that the middle finger and the index finger are overlapping with each other. So overlapping of the digits is a prominent finding. Digits means I'm talking about the fingers is a prominent finding. Okay, they also have a short neck. And one more striking feature is that when you look at the foot of this children, okay, it is written as prominent heels. Okay, so the backside of the legs is very prominent, or the heels are prominent. And one more important point is that the legs are curved like this. Can you notice that? It is not a normal curvature of the legs. Okay, it's a curved foot region which resembles like this. What is that? This is the rocking chair which you can see in this picture, and you can see the bottom of the rocking chair. I am talking about this area, the bottom of the rocking chair. Can you see it is also curved like this? So that is why the appearance of the foot in a child with Edwards syndrome is characteristically remembered as rocker bottom foot. Rocker bottom foot. Okay, and they also have limited hip abduction. Limited hip abduction. Okay, these are the important external appearances of a child with Edwards syndrome. You should also know about some important internal problems or defects associated in the organs in a child with Edwards syndrome. Here again, the most common group of defect is cardiac defects. Here, cardiac defects are so common that it is encountered in more than 90% of babies with Edwards syndrome. If you can remember, this is a very high number. Why? Because in Down syndrome, I told you it is 50% cases, but here it is more than 90% of cases will have a cardiac defect. And the most common cardiac defect is VSD, that is ventricular septal defect. This is followed by patent ductus arteriosus, and the third one is atrial septal defect. You should correctly remember this order of heart defect because it has been asked once in the exam regarding the most common cardiac defect in Edwards syndrome. But VSD was not given in the option, so you have to choose the second common cardiac defect, that is PDA. So that is why I want you to remember the order of cardiac defects in a child with Edwards syndrome. They also have increased incidence of renal defects. Especially they have an increased incidence of horseshoe kidneys. Okay, these are the important associations of Edwards syndrome that one should know about. Next, we are moving on to the Patau syndrome, which is trisomy 13. Now, this is a description of the classical findings encountered in Patau syndrome. Here again, some of the characteristic facial features one should know about. Here you can see, obviously, there is a cleft lip or a palate. And remember, this association is very strong for Patau syndrome when compared to the previous Edwards syndrome, because in 60 to 80% of cases, it is associated with cleft lip and palate. Okay, so remember, both Edwards syndrome as well as Patau syndrome have an increased risk of cleft lip or palate, but more association or more incidence of cleft lip and palate is noted with Patau syndrome only. That's an important point to be noted. That is number one. Second, the eyes appear to be small. Again, it is microphthalmia. Third important feature is you can see that the ears are dysplastic or malformed ears. Okay. The fourth important feature is they have an increased risk of scalp defects, which is aplasia cutis. Okay, there is an absence of skin in a particular part of scalp of these children. That is called as aplasia cutis. Usually the scalp area is getting affected here. Next, you look at the fingers. You can very easily notice that these children are having an extra finger. 1, 2, 3, 4, 5, and the sixth finger is there. Okay, so this is the extra finger which is noted in these children. I can also show in this picture also. Can you notice very clearly the extra finger in this particular child? This is what we call it as polydactyly, and that too post-axial polydactyly. Post-axial polydactyly, which is characteristic. And other finding is that the fingers of this particular child are curved, similar to what I told for Down syndrome. What is that curved finger called? Yes, it is called as clinodactyly. These children also have increased incidence of other defects like undescended testis or cryptorchidism. They also have increased risk of heart defects, around 80 to 90% of the cases. So that means it is still less than what we have studied for Edwards syndrome. In Edwards syndrome, heart defects are more than 90% cases. Here it is 80 to 90% of cases. And here again, the sequence of heart defect is important. The same sequence which I have told before only. First is VSD, followed by PDA, followed by atrial septal defect. Okay. And the other important defects which are associated are absent ribs, or what the radiologist would report as missing ribs. Okay. And last important point is some of these children can have an increased incidence of anomalies in the brain. Okay. And that too a very important anomaly which should be remembered as hollow prosencephaly, which is also called as arynencephaly. More about the description of this neurological defect has been discussed in the modules under nervous system. So these are all the important associations of Patau syndrome or trisomy 13 that one should be knowing about. So till now what we have discussed is about the important group of trisomies in children: trisomy 21 or Down syndrome, trisomy 18 or Edwards syndrome, and trisomy 13 or Patau syndrome. We now move on to the discussion of other aneuploidies in children. The next aneuploidy I am going to discuss about is the monosomy X. What is monosomy X? It is just one X chromosome in a female instead of two X chromosome, and that is what is called as a Turner syndrome. So how it is represented? It is represented as 45XO. O refers to the absent X in a female. What is the genetic basis of this missing X chromosome? It is due to loss of X chromosome during the time of gametogenesis. Okay, and it is especially observed during paternal gametogenesis. Remember, it is not maternal, it is paternal gametogenesis. This is the most common reason why a baby with Turner syndrome develops. Okay, and if you look at the karyotype analysis of patients with Turner syndrome, 57% of the patient, or most patients, they will have complete monosomy X, and 29% of the patients, they are mosaicism. That means what? They have a combination of normal cells as well as cells with monosomy X, and remaining 14% will have a partial monosomy. What is the meaning of this? They have the other X chromosome which is not completely deleted, but something like a ring chromosome or a isochromosome. That is what is called as the partial monosomy X. Okay, these are the genetic defects in Turner syndrome. Now we are going to look at the important clinical characteristics of a child with Turner syndrome. The most striking feature in a child with Turner syndrome is the short stature. Usually the height of these children is less than 145 centimeters even in the adult age. Okay, right. So one is the short stature. Next is about the external appearances. They have a triangular face. Okay, and in the neck region they have loose skin folds with the webbing of the neck, and if you look at the back side of the neck, they have low posterior hairline, and in the chest region they have flat chest, or what you also call it as the shield chest, with the nipples which are widely spaced from each other. Widely spaced nipples. If you look at the hands of these children, you can notice a very characteristic problem noted here. That is, there is a wide deviation at the level of elbow. What is this called? This is called as an increased carrying angle, which is more than 135 degrees. And this increased carrying angle is what we call by a medical term. What is that? Cubitus valgus. Okay, and if you look at the fingers of these children with Turner syndrome, they have short fourth metacarpals. Okay, and another important striking feature is in the heart, and second thing is in the gonads. In the heart, they have an increased risk of heart defects. The common heart defects include bicuspid aortic valve. That is the most common heart defect. Followed by that, there is a coarctation of aorta. Okay, and in the gonads, that is the ovaries. The ovaries are not well developed, what is called as the streak ovaries. And because of streak ovaries, the estrogen production is very low, and this results in the problems of infertility and amenorrhea. These are the characteristic clinical features of a child with Down syndrome. Now, you should also know about what could be the presentation of Turner syndrome in a neonatal period or during infancy. In a young child, it classically presents with what is shown in the picture. What is that? You can see that this is the dorsal aspect of the foot, where you can see in both these regions there is a lot of edema. So the characteristic feature in neonate, or if they ask in infancy, it is dorsal edema. Dorsal edema, and this is attributed to lymphatic obstruction. Okay, so I will call this as lymphedema. Dorsal lymphedema of the hands and the feet. Sometimes this edema can occur in the neck region also, where it would be called as cystic hygroma. And this association of cystic hygroma with Turner syndrome has already been asked in the exam as an MCQ question, so you should make a note of it. Okay, so in a small child, always remember edema, lymphedema of the hands, feet, and sometimes the neck region. Okay, so having seen about the features of Turner syndrome, let us look at some of the important one-liners asked in Turner syndrome. In Turner syndrome, there is usually normal IQ. Very important, because in most of the chromosomal aneuploidies, you will learn low IQ, but here there is a normal IQ. However, these children have learning disabilities. Okay, that should be noted. Normal IQ, but they have learning disabilities. Okay, next important point to be noted is Turner karyotype, that is 45XO, is the most common karyotypic abnormality noted in spontaneous abortions during pregnancy. Spontaneous abortions during pregnancy. Right. So many of the Turner syndrome fetuses, they get spontaneously aborted in utero. This is very important. Okay. And two important one-liners are here, which I want you to bring to your attention. First is the most common chromosomal abnormality associated with spontaneous abortion in pregnancy is the Turner karyotype or 45XO. But if the question is asking the most common trisomy associated with spontaneous abortion in pregnancy, then your answer has to be trisomy 16. So please look carefully at what the question is asking and answer accordingly. Okay. We know that in Turner syndrome, the two important problems are short stature and low estrogen. That is why in the management of these children, you have to give estrogen replacement till they attain secondary sexual characteristic. Along with that, you can also give growth hormone as recombinant growth hormone which is being written as RGH, as injections, okay, for them to attain height. So these are the two usual things in the management of children with Turner syndrome. Now look at this clinical case scenario type of question. You have a short child, and along with that there is shield chest, cubitus valgus, webbing of the neck, and a triangular face. Now if I say that these features are present in a female child, what would be your diagnosis? Undoubtedly you will say that it is Turner syndrome. That is a description which we have discussed just before. Suppose I say that the same features are present, but it is a male which is affected. Okay, then what could be the condition? This is something which would resemble the features of Turner syndrome, right? Because all the features which I have listed above are characteristic of Turner syndrome. But the same thing is present in another syndrome also, but the difference is that it is occurring in a male. So it is also called as pseudo-Turner syndrome. Any guesses on what could be this name? Yes, it is Noonan syndrome. Very important, Noonan syndrome. Right. So it is got an external appearance almost similar to that of the Turner syndrome. That is why it is called as a pseudo-Turner syndrome. An important point to be noted is not only males are affected in Noonan syndrome, even females are also affected in Noonan syndrome. Why? Because Noonan syndrome is an autosomal dominant disorder related to chromosome number 12. To be very clear, it is chromosome 12q, that is long arm of chromosome 12 to 4.1. Okay, and this is related commonly to a gene defect called as PTPN gene. Okay, the expansion of PTPN is protein tyrosine phosphatase non-receptor. That is called as PTPN gene, which is the most common defect encountered in Noonan syndrome. Okay, now I will put up a picture of Noonan syndrome and tell you the similarities with the Turner syndrome. Can you see in this picture the very characteristic resemblance to Turner syndrome? One is the appearance of the face. Can you notice this triangular facial appearance? It is attributed to small chin, okay, which is also noted in Turner syndrome as well. Second important point is, look at that chest region. It is a flat or the shield chest, and you can very clearly notice there is a widely spaced nipples also. The next thing is the cubitus valgus, which is increased carrying angle, and you can also notice that there is a webbing of the neck. All these are characteristic features seen even in Turner syndrome also. So that is why I was telling that Noonan syndrome and Turner syndrome will have external appearance which is almost similar to each other. Whenever you have two conditions which are mimicking each other, you should also know the differences between these two conditions. This table will help you to remember the differences between the two conditions. First is regarding the karyotype. Remember, Turner syndrome is monosomy X, so the karyotype is 45XO, and only females are going to be affected. Whereas Noonan syndrome is an autosomal dominant disorder, so karyotype is completely normal. It is 46XX if it occurs in a female, or 46XY if it occurs in a male. Remember, both males and females are affected in Noonan syndrome. IQ, I told you very clearly that Turner syndrome is an exception in the sense that IQ is usually normal in this case, whereas Noonan syndrome is associated with low IQ. Next, about the gonadal defect. In Turner syndrome, we studied that there is streak ovaries. So there is problems of amenorrhea and infertility, whereas for Noonan syndrome, it is cryptorchidism. Usually the males are affected more, so it is cryptorchidism. Okay, and because of cryptorchidism or undescended testis, there is low testosterone leading to delayed puberty and low fertility as well. Okay, cardiac defect, I told you in Turner syndrome, it is bicuspid aortic valves and coarctation of aorta. Whereas for Noonan syndrome, it is PS or pulmonary stenosis. Second important group is HOCM, that is hypertrophic obstructive cardiomyopathy, and they can also have atrial septal defect as an association. These are the set of cardiac problems associated in Noonan syndrome. So this table helps you to remember the differences between the Turner syndrome and Noonan syndrome. Even though Noonan syndrome is not an aneuploidy, I am discussing it here because of its resemblance to Turner syndrome and also to highlight the differences from the Turner syndrome. We come to the discussion of last disorder in this chromosomal aneuploidy, and that is Klinefelter syndrome. Klinefelter syndrome is considered to be the most common sex chromosomal aneuploidy. And what is the karyotypic abnormality in Klinefelter syndrome? It is 47XXY. Okay, and where is the extra X coming from in case of Klinefelter syndrome? It is due to non-disjunction of X chromosome during meiosis. This happens at the time of gametogenesis. This gametogenesis could be either in the paternal side or in the maternal side. Okay, it is noted that both paternal and maternal defects are equally contributing to this particular condition. Okay, so 50% of the cases it is a paternal defect and 50% of the cases it is maternal defect. Okay, right. And in this particular condition, increasing age or advanced paternal age is considered to be a risk factor. Very important, in most of the trisomies, we read that it is the increased maternal age which is a risk factor, but in Klinefelter syndrome, increased paternal age or advanced paternal age is a risk factor. Now let us look into the clinical features of a child with a Klinefelter syndrome. The very first thing which you will observe while looking at a child with Klinefelter syndrome is that the child appears to be unusually tall. Okay, especially you can see that the legs are unusually very long. So long legs is a characteristic feature which contributes to tall stature in these children. Another important association which you should know is with regards to gonads. It is undescended testis, or what we call it as cryptorchidism. Because of cryptorchidism, there is low levels of testosterone. Okay, so what is the problem? The secondary sexual characteristics will develop very, very late. You can see in this particular child, he is already an adolescent boy, say around 15, 16 years like that, but he has not developed secondary sexual characteristic. Can you notice that he has not developed this axillary hair and the facial hair? Okay, very evident is he has no facial hair. Okay, which may be a feature that is secondary sexual characteristics are not developing even at this age. Okay, this is what we call it as eunuchoid body habitus. Okay, eunuchoid body habitus. Okay, so they will have absence of axillary and facial hair. The penis appears to be small. Even the testis appears to be small in size. And in late stages, this testis can even undergo atrophy also. Especially there is atrophy or degeneration of the seminiferous tubules. And because of this, they have an increased incidence of infertility. And this fact has been asked as an exam question also, that Klinefelter syndrome is the most common cause of, or the most common genetic cause of infertility and hypogonadism in males. Okay, right. And one more important and interesting question to be noted here. What happens to the puberty occurrence in a child with Klinefelter syndrome? Very important point is many of the texts are giving different answers, but I want you to remember this with the standard reference from Opigai as well as Nelson textbook, which clearly mentions that puberty starts at a normal age. However, the progression of puberty is very delayed. That is why generally most of the books give the answer as delayed puberty. Yes, it is delayed puberty, but in a correct sense, it is delayed progression of puberty. That is what you need to remember regarding the puberty association in Klinefelter syndrome. Okay. Now, the other finding which you can notice in these children is from the picture itself, where you can notice there is an enlargement of the breast region, which is what we call it as gynecomastia. And we all know that gynecomastia occurs due to the influence of estrogen or estrogenic metabolites. Now, how does that come in a male child? This is due to increased activity of an enzyme called as aromatase. What does this aromatase do? It will convert the testosterone into estrogenic metabolites. These estrogenic metabolites includes estradiol, which is going to stimulate the breast tissue and cause the development of gynecomastia. So basically it is due to increased levels of estrogen metabolites in the body of a child with Klinefelter syndrome. And this estrogen metabolites are also going to be associated with the increased risk of male breast cancer. This is an MCQ question by itself. Which genetic disorder predisposes to development of male breast cancer? It is Klinefelter syndrome. Okay. Other than this, these children definitely will have low IQ. They also have learning disabilities. Especially their verbal skills are going to be affected. When they become older, they also develop behavioral problems. And this condition is also associated with the increased risk of cancers. One of the cancers I've already told you is a male breast cancer. And the second important group of cancer which occurs in these children is that they have increased risk of extragonadal germ cell tumors. Especially in the mediastinum. Usually in the anterior mediastinum is where they commonly develop this germ cell tumors. Okay. So remember, Klinefelter syndrome is a condition which has got lot of important abnormalities, not only with related to puberty and tall stature, they also have increased risk of cancer as well. So that is about the discussion of Klinefelter syndrome. And with that, we complete the discussion of important aneuploidies in the pediatric population. The next group of genetic disorders is microdeletion syndromes, which includes two main disorders, namely Dijot syndrome and Williams syndrome. Microdeletion refers to a small deletion which is not detectable on karyotyping. That is why they are called microdeletions. And what is a way to detect these microdeletion? It is by a special investigation called as FISH. What does that FISH stand for? It is an expansion of fluorescent in situ hybridization. That is a usual investigation by which we diagnose this microdeletion syndrome. Let's start with the discussion of the first important syndrome, which is Dijot syndrome. In this condition, the microdeletion involves the chromosome number 22. To be very specific, it is long arm of the chromosome. So 22q 11.2 microdeletion. That is the actual location of deletion in Dijot syndrome. In Dijot syndrome, there is also abnormalities in the development. Abnormalities in the development of some pharyngeal pouches, namely third and fourth pharyngeal pouches. You all know that from the third and fourth pharyngeal pouches, thymus and the parathyroid will develop. So in this condition, you will have defects in both thymus as well as parathyroid. The important features of this particular condition can be remembered by a mnemonic called catch 22. 22 actually refers to the deletion, which I have already said. What is the expansion of catch? C stands for cardiac defects. And these cardiac defects are remembered as conotruncal defects. Which includes conditions like TOF, that is tetralogy of Fallot, interrupted aortic arch, as well as right-sided aortic arch. All these are included under the category of conotruncal defects. Next one is the A. A here stands for abnormal facies. The picture depicts the abnormal facial appearance noted in a child with Dijot syndrome. The important points to be noted here are they have widely separated eyes or hypertelorism. Next thing, if you look at that mouth region, they have a thin lips, especially the upper lip is thin. They have a small mouth. Even the jaw appears to be small. They have small jaw. And the next point is, look at the ears of these children. It is again low-lying ears, and most of the time these children have a notch in the ears like this. Okay, so the next important characteristic feature in the facial appearance is low-lying as well as notching of the ears. So all these contribute to the abnormal facial appearance noted in a child with Dijot syndrome. The next one is T, which stands for T cell deficiency or T cell immunodeficiency. This is because of the thymus, which is not developed properly as explained before. So it is due to thymic hypoplasia, or in some cases you even get aplasia. Okay, so T for T cell immunodeficiency. Next one, C. Even though it is not shown in this picture, these children have an increased risk of cleft lip as well as cleft palate. Last one is the H. H is for hypocalcemia. What is the reason for this hypocalcemia? It is because I told that because of the defective development of the third and fourth pharyngeal pouches, I told that in addition to thymus, parathyroid also will not develop properly. So what happens? The levels of parathyroid hormone will be decreased. PTH level will be decreased, and that predisposes to hypocalcemia. And because of hypocalcemia during infancy, these children can also present with seizures as well. These are the salient features of Dijot syndrome. The other important name of this Dijot syndrome is velocardiofacial syndrome. You can understand this name easily from the features of the Dijot syndrome itself. For example, velo refers to velum, which is something related to palate. I told that these children will have cleft palate, so that's why velo. Cardio refers to the cardiac problems which are encountered in this condition, which includes the conotruncal defect. And facial refers to the facial abnormalities which I have put up in the picture. So that is why this condition is also called as velocardiofacial syndrome. That is the first example of microdeletion syndrome. The next example of microdeletion syndrome is Williams syndrome. Okay, where is the microdeletion here? Here microdeletion is in the chromosome number 7. Okay. Again, long arm of the chromosome number 7. To be very specific, it is 7q11.23 microdeletion. This is an important question to be remembered. Which chromosome has a microdeletion in Williams syndrome? Okay. And the characteristic feature of this Williams syndrome is this facial appearance, which I put up in that pictures. Can you notice that these children, okay, have a wide mouth? Can you notice that very classically? Wide mouth. Okay. They have a prominent forehead. You can notice that from the picture as well. Prominent forehead, as well as puffiness noted in the eyes, as well as puffiness noted in the cheeks. These are very classical findings in case of Williams syndrome. And how does this facial appearance resemble? It resembles like this picture, which refers to that short-statured elves. Okay. Now that is the reason why this type of facial appearance is also called as elfin facies. Okay. So the name is called elfin facies. And similar to what you see in this picture, these children also have a very, very happy faces, or what we also call it as a friendly personality. Okay. These children are generally very friendly, always happy. So that description is also there, friendly personalities. Okay. And there are some associated problems in this Williams syndrome as well. First is regarding the calcium problem. Previously in Digeorge syndrome, I told you hypocalcemia, but here it is hypercalcemia. And second is the cardiac defects. The cardiac defect is a commonly asked exam question, and that is supravalvular aortic stenosis. In this condition also, like most other genetic disorders, they have low IQ and learning disabilities. These are the salient features of Williams syndrome, and with that we have completed the two important examples of microdeletion syndromes. Next I am going to discuss about genomic imprinting disorders. Let us try to understand what it is. Normally for any gene we have two alleles, one from paternal and one from the maternal side. Out of these two alleles, one of the allele is normally silenced or imprinted, and only one allele is active. We all know that. Okay. Suppose a problem occurs to this active allele, then a disorder will occur, and that is what we call it as genomic imprinting disorder. So it usually occurs due to a problem of the active allele. That problem is usually in the form of deletion of the active allele. That is the main cause of genomic imprinting disorder. Okay, right. In some cases, what can happen is the inactive allele will become double, or there are two copies of inactive allele. Then also you will have the same problem, which would result in genomic imprinting disorder. So what I am trying to tell here is genomic imprinting disorder could either be due to deletion of the active allele or two copies or disomy of the inactive allele. Okay. So genomic imprinting is due to deletion of the active allele or disomy. That means two copies of inactive allele. More commonly what happens? It is a deletion of the active allele, which is the most common reason for a genomic imprinting disorder. And there are two examples of genomic imprinting disorder that we should know about. One is Prader-Willi syndrome. The other one is Angelman syndrome. Let us see in detail about the clinical features of these two syndromes. First is the Prader-Willi syndrome, which occurs due to deletion of the paternal allele in chromosome 15q, that is long arm of chromosome 15. To be exact, it is 15q1113. That is the location of the gene, the active allele of which is deleted from the paternal side. Okay, deletion of paternal allele. This is a common reason. It can also occur due to disomy of maternal allele. Remember here, the maternal allele is the inactive one for this particular gene in Prader-Willi syndrome, but that becomes 2 in number. That is what we call disomy of the maternal or the inactive allele. Okay, which is a common variety. As I said before, common variety is always deletion of the paternal allele. Okay, this is the common cause. Remember like this, Prader-Willi with P and paternal allele with P. So in Prader-Willi, there is deletion of paternal allele. That is a point to be noted. Okay, now clinical features is what I want to concentrate here. The most important clinical feature you can realize by looking at the child itself is that there is obesity. Okay, obesity. And in this particular child, it is supposed to be due to increased intake of food, or in other words, we can also call it as hyperphagia. Okay, hyperphagia is attributed due to increased levels of an hormone which normally stimulates the appetite or food intake. What is that? It is ghrelin. Okay, and this has been asked as a question. Which hormone levels are increased in Prader-Willi syndrome? It is ghrelin, which increases the food intake, thereby causing hyperphagia and obesity. Okay, second important feature is these children appear to be short. When compared to normal children of that same age, they are definitely having short stature. Next important feature is they have small eyes, or what is also called as the almond shaped eyes. They also have small hands as well as small feet. Okay, the next important point is they don't have a properly developed gonads, okay, resulting in hypogonadism, and because of which they also have delayed puberty. These children also have associated low IQ. So these are the most important features of Prader-Willi syndrome that one should know about. The commonly asked exam question is deletion of which allele? It is paternal allele. Remember, P for Prader-Willi and P for paternal allele. We now move on to the next condition, that is Angelman syndrome. Here also the problem is in the same chromosome 15. Okay, but the location is slightly different. It is chromosome 15q1112. That is the location of the gene in this particular condition. And here what happens? There is deletion of the active allele. Here the active allele happens to be maternal allele. So it's a deletion of maternal allele. So remember like this, in this particular condition, maternal allele is the normal active allele and that becomes deleted, resulting in Angelman syndrome. It could also be due to disomy of the other one. What is that inactive allele here? Yes, it is paternal allele. So it is disomy of the inactive paternal allele. Okay, so any one could be the cause, but as always, the common cause is deletion of the active or the maternal allele here. Okay, now let us focus on the important clinical features of this particular condition. Okay, in this condition, there is inappropriate laughter. They will always be laughing all the time, inappropriate laughter. Along with that, they have instability in the form of ataxia. So what happens? Hands and feet will always be having that involuntary movements. Along with that, they also have a inappropriate laughter. So that is why combining these two features, it is given the name as happy puppet syndrome. Happy puppet syndrome. So something like puppets, they are uncontrollably moving their hands and feet due to ataxia, and always because of that laughter, they are called as happy puppet syndrome. Okay, and they also have very low IQ. The IQ is lesser even when compared to the previous condition, that is Prader-Willi syndrome. That's why I've written very low IQ. They also have increased incidence of seizures. These children also have hypotonia as well as feeding difficulties. So please remember, in Angelman syndrome, two important questions are there. One is which allele gets deleted. Here it is the maternal allele. Remember, Prader-Willi syndrome, it is a paternal allele deletion. That's the difference which you should know. Second important feature of Angelman syndrome is happy puppet. These are the two commonly asked questions in Angelman syndrome. And with that, we complete the discussion of two important genomic imprinting disorders. Next, we are going to discuss about other important genetic syndrome, which is Treacher-Collins syndrome, a commonly asked question in your competitive exams, and that is why I am discussing here. Treacher-Collins syndrome is an autosomal dominant disorder. And the other name of this Treacher-Collins syndrome is mandibulofacial dysostosis. You can understand from the name itself, they will have defects in the mandible, they will have some abnormalities in the facial appearance. That is why it's called mandibulofacial dysostosis. Let us see what are the abnormalities with the help of this picture. The first important feature is that the slant of the eyes, please concentrate on the slant of the eyes, it is sloping downwards like this. If you remember, in the previous discussion, I said for Down syndrome, it is the upward slanting of the eyes, and I call that as mongoloid slant. Here it is opposite, downward slanting of the eyes. So I will call this as anti-mongoloid slant. Anti-mongoloid slant of the eyes. Okay. They also have defects in the lower eyelids. Okay, called as a coloboma of the eyelids. Okay, they also have sunken cheeks. And if you look at the mandible is not well developed, okay, underdeveloped or a small mandible. And because of this small mandible, the teeth in that lower jaw is not aligned properly. Okay, this gives rise to dental malocclusion. The other feature includes abnormal hair distribution. I would want you to concentrate on this picture itself. You can notice that this is that auricle region in the ear. In front of the auricle, the hair is coming forward. Okay, so this is called as the pre-auricular hair displacement. It's a very characteristic feature in this condition. Then you have to remember that these children have an increased risk of conductive hearing loss. It is because in this condition there is malformation of the ossicles as well as defective development of the middle ear cavity. This is the reason attributed to conductive hearing loss noted in children with Treacher-Collins syndrome. And the final point is an important point often asked as MCQs. What happens to intelligence of these children? Please remember, in spite of all the problems I have mentioned before, surprisingly, the intelligence appears to be normal. and this is a commonly asked MCQ question as well. Okay, they ask you like this: what are all of the following are features of Treacher-Collins syndrome except like that? They may say low IQ or intellectual disability, which is a wrong statement because they usually have normal IQ. That is a point to be noted. Okay, so these are the important features of Treacher-Collins syndrome. Next, we are going to discuss about an interesting condition called Peary-Robin sequence. Please note the word, I am using the word sequence and not syndrome, because this is not a condition by itself. It is associated with some other conditions, and you have a chain of events which are developing. That is why it's called as a Peary-Robin sequence. Now, the common starting point for development of Peary-Robin sequence is a severely underdeveloped mandible. Okay. As you can see from the pictures I have put up, can you see that if that mandible is normally developed, it should be having a size like this. But here, there is no proper development of the mandible. That is what I have written as severely underdeveloped mandible. In this particular condition, the problems are going to start in utero itself. That is, before birth of the baby itself, all the problems are going to occur. And the sequence will happen one after another in the following way. Because of severely underdeveloped mandible, what happened? The tongue, okay, is not able to be positioned properly inside the mouth. It is getting pushed back. Okay, this tongue getting pushed back is what we call it by a special name, retroglossoptosis. Okay. What is the problem? When the tongue is getting pushed back, where it is hitting? It is hitting on the palate region. So, it will interfere with the development of palate. It will interfere with the development of palate. Resulting in an important problem. What is that? Obviously, it is cleft palate. Remember that here the cleft palate will be a very big cleft palate, and what would be the shape of the palate? It is U-shaped. You can imagine that this U shape corresponds to the contour of the tongue. Okay, so that is why, because the tongue is interfering with the development of the palate, you get a U-shaped big cleft palate. Are you able to follow this, right? Now this cleft palate, which is very big in size, can predispose to aspiration of feeds after birth. Aspiration of feeds after birth. Okay, it's a very important problem in these children. The second important problem is, because the tongue is getting pushed back, it can also cause airway obstruction after birth. Airway obstruction after birth. So you can understand the chain of events which are occurring due to severely underdeveloped mandible, and that is what we call it as Peary-Robin sequence. Okay, and you should know some important associations of this condition. Fetal alcohol syndrome is an important association. And one more important association is with the trisomies, especially trisomy 13 is an important association with Peary-Robin sequence. Even the previous condition which I discussed, that is a Treacher-Collins syndrome, there also if the mandible becomes severely affected, then also the child can go in for Peary-Robin sequence. Okay, so please understand, Peary-Robin sequence is not a condition or a diagnosis by itself. It is associated with some other problem, and the main feature is severely underdeveloped mandible, from where all the other problems would develop further. So that is about discussion of Peary-Robin sequence, and with that we are completing the discussion of genetic disorders in children.